Good afternoon. We will go ahead and get started. Thank you all for coming on this unusual day for Grand Rounds. This is a wonderful turnout, so welcome to all of you. It's my pleasure to introduce our speakers today, Jan and Kristina Sundquist, who are visiting from Lund University in Sweden. It's been my privilege to have known Jan and Kristina for the past 8 years and to collaborate closely with them, first from Stanford University and now from Mount Sinai. Both Jan and Kristina are epidemiologists and family physicians. Jan received his MD from Umeå University in Sweden and his PhD in epidemiology from Lund University in Sweden. He did postdoctoral fellowships both at Lund and at Stanford University in California. Kristina received her MD from Uppsala University and her PhD from Karolinska, where she also did a postdoctoral fellowship. They moved to Lund. They served first as faculty at Karolinska for a number of years, where Jan was the chair of the Center for Family Medicine and Community Health, before moving to Lund University around 2008, where they currently lead the Center for Primary Health Care Research, which is one of the largest centers of its kind in Europe. Both Jan and Kristina have a long track record of leading large NIH-funded epidemiologic studies in Sweden, including many innovative study designs in the areas of cardiovascular disease, mental health, and cancer. Much of their work has had a focus on social and neighborhood effects on health in the most vulnerable populations. They both have published several hundreds of papers and have won a number of research awards. And I can tell you firsthand, they are both terrific people and great friends as well as wonderful scientists. I think they're going to take turns giving this talk, but please join me in welcoming Jan and Kristina Sundquist.
So I start, and then Kristina continue, and then I continue, and Kristina later. We are honored to be here. We are very happy to be here in New York. For me, the first time. Kristina, the third time. So that's beautiful. We have only seen California before. So we are located in the southern part of Sweden, in Malmö. It's 20 minutes from Copenhagen Airport in Denmark, from our department. So it's pretty convenient. To go to New York is to take the bus, I think, and then we are here. And our university in Sweden, we have around 1,300 students studying medicine each year. And the basic training is 5.5 years. And we have 7 medical universities in Sweden. The oldest of them is Lund University from 1666. Innovations at Lund University, well known and well established, is the use of ultrasound. It was invented at Lund University. The artificial kidney, and also non-ionized contrast medium, and a new ventilator of Björn Jonsson. Also established in Sweden and international is protein G and L of Lars Björk. And test for risk of blood clots is Björn Dahlbeck. And it's amazing, when we started our experimental lab 5 years ago, he has been our mentor and helped us a lot to perform research, experimental research. We have also Lund model for treatment of head injuries from the 1990s. And innovations for the future, Jan Nilsson, is a vaccine against heart attacks, which is pretty new. A drug that speeds up slow childbirth, of Dr. Malmström, and endogenous peptides against bacteria. Sweden, we have almost 10 million inhabitants. 9% of our brutto national product is used for healthcare. 9% are 75 and older. 7% unemployment. 1.7 million born abroad. So there is diversity in our country. And only last year, 163,000 applied for asylum in 2015. And that is 10% of the entire population in Sweden. We could talk about that the whole hour, so I continue. This is the different groups. Today, still Finland is the largest immigrant population, then Iraq, followed by Syria, which is increasing from 2014, 2016, from 42,000 to 98,000. And then it's Poland, Iran, Bosnia, Somalia, Yugoslavia, Turkey, and Afghanistan. Our county in south of Sweden is the most southern county. We have 1.3 million inhabitants, and we have around 152 primary healthcare centers. 20% of immigrants born outside Sweden live in the county. And we have 40% of the primary health care centers are private. There work around 1,000 primary health care physicians and 3,000 nurses. This is the Western Harbor in Malmö, facing against Denmark. This is a little bit of the countryside outside Malmö. It's beautiful. Our county decided in 2008, together with the university, to start a Center for Primary Health Care Research in 2008. And it's a collaborative venture between the region and Lund University. It's located in a clinical research center where we have 40 different research groups, 420 scientists, 400 undergraduates. So it's a fantastic environment for research. I think that's why we left also Karolinska, where we were full professors, because we thought we had much larger opportunities in such a modern research environment. The CPF, the Center for Primary Health Care Research, is the acronym in Swedish. We have grown during the years and features today other units, some also a competence center for primary care. And the vision of that is equal health, equal treatment, and a highly competent staff. The Center for Primary Health Care is to pursue groundbreaking clinical research for primary care of the highest quality and help benefit a healthier population as a consequence. I think that's why the county want to support us. They want us to be a good recruitment for primary health care physicians from other places. CPF has today 51 employers in our multidisciplinary team by Lund University or Region Skåne or both. Our researchers have all links to primary health care. All researchers have to work clinically from 1 to 4 days a week. The Competence Center for Primary Care, KCP, has 64 employees for education and development of primary health care. And that is something different. They have the responsibility for the training of 300 residents in primary health care. And together, we act as a cohesive platform for research, education, and development in primary health care in both the private and public sectors. We have 5 professors of family medicine, 1 professor in nursing, 1 university lecturer and 2 professors in social medicine and public health, and 1 professor of health economics. We place a specific focus on research areas that are particularly important for patients in primary care, like cardiovascular diseases, depression, anxiety, alcohol use disorders, cancer epidemiology, elderly health and drug prescriptions, infectious disease, and comorbidity. We have 7 doctoral students graduated in 2015. We have 40 current doctoral students projects. We have an analytic and database support section with 4 statisticians, 2 database managers, 1 GIS engineer, and 2 epidemiologists. Here is the brain trust at CPF. Important because we are doing so many epidemiological studies and large databases. Our team supports then clinical research, experimental research, epidemiological research. This is a team meeting. It was published in Circulation 2012. The molecular family medicine laboratory is also important because we are doing interventions and clinical studies, and then we can analyze the blood samples ourselves. We have an international collaboration with Heidelberg, Virginia, Commonwealth in drug use disorders. With Ken Kendler, Kari Hemminke is with Heidelberg on cancer. And we collaborate, you know, Marilyn Winkleby. In Sweden, I have to say, we collaborate with the lady to the right, because if they don't know who is on the left side, a little bit stupid, perhaps. We also collaborate with John Ioannidis at Stanford. And now we start collaborating with Mount Sinai. We think that is excellent. That is fantastic. We have a lot of data sources in hospital discharge register, and we have data on every individual person, but we don't have their ID. The ID and the key has Statistics Sweden, but we can connect different registers. And we have the outpatient register from 2001. We have the cancer register. It's very complete, this register, very, very complete. And we have the drug register from 2005. It's all registrations of prescriptions in Sweden from 2005 in July. I don't think there is hardly any missing data. It's almost 100% complete. And that is prescription from private physicians, from all types of, and connected with the other databases. We have the twin register, and that we are allowed to use for mental disorders, but we can do other diseases, but then we need permission from the owners of the register. We have the population register, school registers, all assignments from children when they are graduated at 15 years old. We have the multi-generational register, so we can see who is the cousin, who is the nephew, who is the parents, and if you change, if you divorce, and everything like that. And that means that we can do very innovative epidemiological studies, which is very close to causality. With a military register, we have crime register, etc., GIS database, and we are focused on these phenotypes of disorders. And in the laboratory, we are interested in cytokines, ApoM, microRNA, telomeres, etc. And we are performing spatial epidemiology. Co-sibling design is very new, and I think we are one of the first to use that. You can never say that you are the first, because there are always a few others who have done it before. And we have our primary healthcare centers, and we're doing the clinical studies, etc. We have a geographical database, so all these persons included in the database, we don't have the address, but Statistics Sweden have geocoded every address. We can't have it exactly. It is randomized at 200 meters from the real address, but it gives a pretty good shape, a pretty good picture of geographical based studies. In 2015, we published 110 original articles in good journals. We can better, but. And now it comes to a few studies. Kristina can continue with more the science.
So I'm also, of course, very honored to be invited to come here today, and I will present a few examples of the studies that we conduct at the department. Please feel free to ask questions at any time. For example, we have performed a study where we examined the risk of coronary heart disease and stroke among spousal caregivers of cancer patients. And it was possible to identify the cancer patients in the Swedish cancer registry, and the information on their spouses was retrieved from another one of the Swedish national registries, and they are all nationwide. They include almost 10 million people, and actually even more than that, because we have also included deceased people. So in total, 13 million people are in the database right now. We found that the spousal caregivers of patients had increased risk of CHD and stroke, and this increased risk persisted over time, and the increased risk started the year after cancer diagnosis. And this shows that spousal caregivers are at increased risk of cardiovascular diseases and that they deserve clinical attention. Another paper, which was also quite innovative, included patients with all 33 different autoimmune disorders and followed these individuals for hospital admission for pulmonary embolism. In total, more than 500,000 individuals were admitted to hospital because of an autoimmune disorder during the study period. And we found that the risk of pulmonary embolism was strongly increased. As you can see, it was increased to 6.38. And these findings show they cannot immediately say something about the mechanisms, but they can help to shed light of where can the scientists look for the answers. So we have always thought that clinical research, epidemiological research, and experimental research, everything under the same roof, is ideal for research. Often we get the ideas in clinical practice. Here's another paper published in Cardiovascular Genetics, Circulation, Cardiovascular Genetics. It examines the risk of stroke among relatives to individuals with venous thromboembolism, but it also examines the risk of venous thromboembolism among relatives to individuals with stroke. So we found that there is a link between stroke and venous thromboembolism. Next, I know that so many of these things does not seem to be cohesive, but this is because we have little time to show you the comprehensive nature of our research, and since it is also family medicine, everything, it's possible to study many different types of disorders. My own largest interest has been on neighborhood studies, and for example, it has been shown in many studies worldwide that neighborhood deprivation is associated with many types of diseases, even after adjustment for individual level socioeconomic characteristics. But the mechanisms behind the neighborhood deprivation effect on individuals' health has been difficult to elucidate. So we were able to link neighborhood resources to the neighborhoods, like, for example, fast food restaurants, which are more common in deprived neighborhoods, at least in the US. We also linked bars and pubs, physical activity facilities, and healthcare resources in all Sweden. And we were able to link these data to the neighborhood level, to the individuals. So in total, more than 2 million people were included in the study, where we found that there were significant associations between the neighborhood availability of potentially health-damaging and health-promoting goods, services, and resources. There were weak association, but they were present. Now I would like to present one of the studies that we have performed together with Dr. Crump. And we have, I just counted them, we have over 39 published papers with Dr. Crump, and it has been a pleasure, and it has been wonderful to collaborate with Casey. So I know that these are only the published ones, and we have several others in progress. So perhaps one of the most innovative studies was the study that was published in JAMA. It was a national cohort study of 674,820 individuals. They were born between 1973 and 1979, and all of them were born preterm. They were followed for 20.8 million person years, and we found that low gestational age was independently associated with increased mortality in both early childhood but also in young adulthood, because most studies of preterm birth have shown poor health in childhood, but this was the first study that examined mortality in young adulthood as well. And this paper was followed by several others, and almost any outcome is more common among children who are born preterm birth, even in young adulthood, with one exception. It was allergic rhinitis. So that's also exciting. Why is that? This is a new genetic epidemiological design that is possible only through the Swedish nationwide registries and the multi-generational registry. For example, we know from previous research that there is a familiar transmission of drug abuse, alcohol use disorders, and criminal behavior, but it has been difficult to say whether the familial transmission is explained by genes or by a familial environment. But in the national registries, it is possible to identify individuals who have been raised in so-called triparental families. So it's possible to compare, to link these families to the biological mother, and the biological mother contributes with genes and rearing. The biological father that you have not lived with would mostly contribute with only the genes, and the stepfather would contribute with the rearing. And if you know the registration for drug abuse, alcohol abuse, and criminal behavior in those individuals, you can disentangle whether the transmission is due to genes or the upbringing. So we found that the biological mothers transferred drug abuse to the highest extent, followed by the not lived with fathers, and lowest for stepfathers, but still twice the risk. This shows that both genetic factors and rearing are important. Not surprisingly, but it gives a possibility to quantify what is most important. Is it the genes or is it the environment? It both sheds new light on mechanisms, but it also gives a notion of where interventions should be put. Now I will present Jan's study, which is also quite innovative, I would say. In Sweden, persons with depression and anxiety and stress-related disorders are offered individual psychotherapy, mostly cognitive-based therapy. But of course, individual-based therapy is expensive. And it is also in short supply because we don't have enough psychologists to cover the need. So this study aimed to investigate whether mindfulness-based group therapy is non-inferior to individual therapy. And we expected that it wouldn't be better. We were only interested in whether it would be as good as individual therapy, because if it is, then a lot of money can be saved. Individual-based therapy is very expensive in comparison with mindfulness-based group therapy. So it was an 8-week RCT conducted at 16 general practices in southern Sweden. We included individuals between 20 and 64 years, and they had to fill in a survey, and they scored either more than or equal to 10 on the patient health questionnaire, more than or equal to 7 on the hospital anxiety and depression scale, or somewhere between 13 and 34 on the Montgomery-Åsberg depression rating scale. And the power calculations were based on non-inferiority. That is important. It was not based on that one of them would be better than the other. And we included 215 patients, and we found that in both groups the scores, the depression and anxiety score, decreased significantly, and there were no significant differences between the mindfulness and control group. So we concluded that the mindfulness-based group therapy was non-inferior to treatment as usual, which is quite promising, because this means that we can save a lot of money, and not only save money, but also offer more people the treatment opportunity. So this was one example of one of our clinical studies. Of course, in all type of research, a large problem is the gap between research and clinical practice. So now it's Jan's turn again.
So how can we establish networks and build bridges between research and practice? Then we started academic knowledge centers, some sort of academic primary healthcare centers, in 2008. The mission was to establish networks and build bridges between the academic world and primary care. At every AKC, there is a research coach, a clinically active person who also has a PhD. This is 10 primary health care centers and their research PhD coordinators. They are working at the center clinically 4 days a week, and then these persons, they stay at the center and give advice to people who are interested at the center or neighboring primary health care centers. And they support a network of primary health care centers with connection to almost all the 150 primary health care centers. At the AKC, healthcare professionals and students receive hands-on guidance in designing and implementing the research ideas. This develops primary health care from the ground. Who should conduct research in primary health care? We don't think everyone can do it. But healthcare workers who are interested in performing research should be able to do it. Good if there is a positive attitude towards research and a supportive atmosphere at the primary healthcare centers. That's important. We encourage interested clinicians to get support from the CPF and the AKC, our network. And the broad range of clinical skills in primary care must be exploited. All professions, small and large projects, is interested. More examples, Kristina.
We were interested in studying school achievement and the risk of eating disorder. Eating disorders have received a lot of attention in Sweden during the last 10 years, and it has been important to investigate the causes behind this seems to be increasing. And previous research has shown that high achievement in school has been associated with an increased risk of eating disorders, and this includes both anorexia nervosa and bulimia nervosa. But the causality of these relationships has been unclear. It has not been known whether it is the actual strive to accomplish that also causes the eating disorders. And we decided that we wanted to examine the association between school achievement and eating disorders in the national cohort, and also to determine the possible contribution of familial confounding by using a correlative design. This study involved more than 1.8 million persons. They were born in Sweden between 1972 and 1990, and they were followed from age 16 years of age for inpatient and outpatient diagnosis through 2012. We used Cox regression to examine the association between school achievement and subsequent risk of eating disorders. We found that eating disorders were much more common among females than males. And we also found that school achievement was positively associated with risk of anorexia among females and males per additional 1 standard deviation of school achievement. We found a 29% increased risk of anorexia nervosa in females, and the same result in males, actually. We also found increased risks of bulimia, but weaker in females, and almost no increase at all in males. So this is how it looked like. In girls and boys who performed well in school, they had an increase in eating disorders over time. We found the same results for both types of eating disorders. So that is when we performed the correlative design, because we wanted to elucidate a potential causal relationship. In the registers, it is possible to link monozygotic twins, full siblings, half siblings, and first cousins to each other. And monozygotic twins, they share 100% of the genes, full siblings 50%, half siblings 25%, and cousins 12.5% of their genes. So we compared pairwise first cousins, half siblings, full siblings, and monozygotic twins that did not have the same school achievement. This would allow us to compare eating disorders in relatives with different levels of school achievement. We found that when the degree of shared genetic and environmental factors increased, the association between school achievement and eating disorders decreased. So this is how it looked like. This is the entire population that shows 29% increased risk of anorexia nervosa in those who have performed well in school compared to those who perform less well. Here is where it becomes interesting, because in siblings, in full siblings, females, there is no difference, as you can see. The reference is 1, and the sibling that performs better does not have a higher risk compared to the sibling that performed poorer. And this type of design helps us to disentangle causality. It was the largest to date to examine the association between school achievement and eating disorder, and we found this increased risk, but these associations are explained by familial confounders, genes, and shared environment. It is not the school achievement per se. So we have spread this knowledge to the schools that it is okay for kids to study. It's not dangerous. And finally, eating is easy, but can be so complicated. Let me also present another study of neighborhood where we assessed the neighborhood walkability in all Stockholm. And we drew 2,400 adults randomly from all Stockholm. And the purpose was to examine the association between neighborhood walkability and walking for active transportation or leisure and moderate to vigorous physical activity. We also wanted to examine whether these associations may be moderated by age, gender, and other socio-demographic factors. The second aim was to determine how much of the total variance can be attributed to neighborhood level differences. We used GIS methods. It was very hard work to do it because we needed to collect data on residential density, street connectivity, and land use mix in all neighborhoods in Stockholm, in total more than 400 neighborhoods. And we used that data to construct the walkability score and defined 32 highly and less walkable neighborhoods in Stockholm City. We picked those who were at the extremes and put accelerometers on the 2,400 recruited participants and collected data on moderate and vigorous physical activity in 7 days. We also assessed walking with the international validated physical activity questionnaire. We found that if you lived in a highly walkable neighborhood, you had higher odds for walking for active transportation, 77% higher odds to walk for active transportation, and 28% higher odds to walk for leisure. We found that the individuals living in the highly walkable neighborhoods had 50 minutes more walking per week and 22 22 more minutes of moderate and vigorous physical activity per week. But we were also able to calculate the total variance, which was low for the neighborhood level, and this indicates that the total variation is more attributed to individual characteristics than to neighborhood characteristics. So we concluded that these differences are not worth redevelopment of neighborhoods, of already existing neighborhoods, because it is time-consuming and expensive. But if you are building new neighborhoods, it is a good idea to look at this evidence. The next study was looking also at neighborhood walkability, including neighborhood deprivation. So we wanted to see whether incidence of type 2 diabetes differed between different types of neighborhoods. And here we included the entire population in Stockholm. In total, more than 500 million individuals. And we also used the co-sibling design in this study as well. We used these multiple nationwide registries and healthcare data. Jan mentioned that this is achieved through a unique individual personal ID number, which is used whatever you do in Sweden. If you go to the doctor, if you get school grades, if you go to the military, or if you go to jail, you will be registered on that personal registration number. And it is replaced, of course, by a serial number because we don't have access to any identifiers. But it creates possibility to examine many different types of epidemiological research questions who are anchored in clinical practice. We were able to diagnose, to identify clinically diagnosed type 2 diabetes through the Swedish prescribed drug register. All picked up prescriptions in Sweden are registered in the same national register. So we were able to detect incidence of diabetes. So we used the geographic administrative units to estimate the walkability indices and included all the individuals born 1988 or earlier. Those who already had collected a prescribed drug were excluded because we wanted to have a washout period, because we wanted to assess incidence. We found that 1.3% of the individuals developed diabetes during the 3-year period. And it was more common in men, which was expected. So this is how it looks like in Stockholm County, the city of Stockholm. We found that diabetes was more common in the less walkable neighborhoods. And also that the walkability was higher in the central areas of Stockholm. We found that those who lived in the areas with the lowest walkability had higher odds of developing type 2 diabetes. Individuals in the first decile of walkability had a 30% higher odds of developing incident type 2 diabetes, and after adjusting for neighborhood deprivation, the results remained unchanged. But when we adjusted for individual variables, age, gender, income, and education, this resulted in substantial reduction of the estimates, and none of the estimates remain statistically significant, which also shows that many of the neighborhood effects that remain are due to residual confounding. So it is important to include as many variables as you can in these types of studies. And we also performed a co-sibling design, which means that we examine siblings that are discordant for walkability, and found that there were no differences between siblings living in neighborhoods that were discordant in walkability. And this is important studies despite the negative results. This is because we have had a large movement all over the world about walkability, and we need to do something about it, but it seems to have a minor importance compared to the individual characteristics. So although it was a very hard job to perform it, I think it is important because we need to focus resources where they are most needed. Rebuilding many neighborhoods for high costs might be less cost efficient than approaching individuals. And finally, a study of neighborhood deprivation and treatment for atrial fibrillation. Here we aimed to study whether there is a difference in the prescribing of anticoagulant therapy in patients with atrial fibrillation. It is important to offer patients with atrial fibrillation proper therapy in order to avoid stroke. So we also were interested in whether the effects of neighborhood deprivation on the relationship between SHADS-2 risk score, and that is a risk score that is calculated to assess the risk of stroke, and warfarin prescription. Warfarin is anticoagulant therapy that is used to prevent stroke. So the SHADS-2 risk score was used to calculate the stroke risk in the patients with atrial fibrillation, and it included the items congestive heart failure, hypertension, age, diabetes mellitus, and prior stroke. Here in this study, we used 75 primary healthcare centers and included the men and women who visited any of the 75 primary healthcare centers in Stockholm County during a 7-year period. The primary healthcare records contain individual clinical data, and they were linked to national data on neighborhood of residence and the deprivation index. We estimated the neighborhood differences in prescribed warfarin, aspirin, and statins. Statins are used to lower cholesterol, and we wanted to examine whether patients who live in deprived neighborhood are less likely to receive correct treatment. And we found that even after adjusting for several individual socioeconomic factors, those who lived in rich neighborhoods or affluent neighborhoods, high SES neighborhoods, were more often prescribed warfarin. So men had 44% higher chance of receiving correct treatment if they lived in the right neighborhood compared to if they didn't. The results for women were not that strong, but still we found that those who lived here, there is a socioeconomic, regional or neighborhood difference. And also prescription aspirin is not something that you actually shouldn't do because it has no effect, it has only side effects. And that was also lower in men from rich neighborhoods compared to those from middle SES neighborhoods. And this shows that the treatment in Sweden, even in Sweden with the equal health care and the universal health care, there are neighborhood differences in how patients are treated. One of the strengths in this study, as in many of our other studies, is that it is possible to link clinical data from individual patients to highly complete national socio-demographic data. And for example, in the clinical records, less than 2% of the diagnoses were missing. And you can also say that a major strength of this study was that it was based on primary healthcare data, and this may probably reflect atrial fibrillation in the population better than hospital data. And at the moment, we are building a nationwide primary healthcare database, which will also give us even better opportunities to study clinical research questions in a large perspective. So I think I already said this, that individuals residing in poor neighborhoods are more often inadequately treated. So we believe that for this particular issue, it is important to address the neighborhoods, since there seem to be differences irrespective of individual data. So thank you very much. Any questions? Jan, you can come up.
Dr. Jan, thank you so much for that great overview of the breadth of research at your research center, and also the integration in your clinical networks. I think that's a wonderful model for other research, primary care research centers. I want to open things up for a few questions. I think we have a few minutes. If anyone has a question, please feel free to use that microphone or this one. I have one just to begin. You mentioned early in the talk the enormous wave of new immigration in Sweden in the past year, and this also has made international headlines. Can you say a little bit about the impact on healthcare in Sweden and population health, and are there plans perhaps to study these effects on health in Sweden?
I think it will be interesting to perform such studies. This is because previous waves of refugees came to Sweden when there was a need for labor immigrants, but today we already have high unemployment rates, and we see that newly arrived immigrants, even those who arrived 5 years ago, have large difficulties to get a job. So I think it will be very important to study what happens with the health of these people who have poorer opportunities for integration compared to earlier cohorts of immigrants.
Very wonderful presentation, complex studies with wonderful databases. As a psychiatrist, I am curious, how much of mental health care is expected to be delivered in primary care?
If you mean percentages, it is difficult for us to say that. I can check it for you if you like. But today we are expected to treat all moderate depressions, anxiety, stress-related disorders. Psychiatric care would take care of personality disorders, bipolar diseases. We don't take care of schizophrenia either, but we are expected to treat alcohol-related disorders and alcohol use disorders. Drug abuse is still taken care of of psychiatrists.
But a first case depression or a first case anxiety would be generally treated by primary care?
Yes, absolutely.
How many of your antidepressants are delivered by primary care versus specialists?
I think, I don't remember exactly, but I think it's at least 75–80% of the patients with depression and anxiety are treated in primary health care. And many of these patients are never seen by a psychiatrist. So I think it's like two different disorders. We called it sometimes psychiatry light, but it's not light for the persons who have it. It's hard.
Thank you very much.
Hello. Very, very nice talk and very intriguing also. I don't have necessarily a question, but I would like to hear some comments on you on, especially the last few studies, the neighborhood studies seem to imply a lot of things that are important for policymakers, for municipalities. How do you guys communicate this, and what is the reaction you get?
We have communicated it to decision makers, and I would say that the decision makers in Sweden are quite interested in this research. The difficult part is doing something about it, because a lot of resources are needed. But the good thing is that they do listen to us, and I also think that these large-scale registries makes it possible to create suggestions where to put the effort at individual level or neighborhood level, because sometimes it is different. If you want people to be physically active, then perhaps you should approach the individuals. If you want people with atrial fibrillation to get the proper treatment, you should approach the primary healthcare centers. So I would say, depending on what kind of question you want to solve, or at least try to solve.
I think we've reached the end of our time. Dr. Sundquist will be around a little bit after this talk. If there are other questions, feel free to hang around. Thank you all for coming. Thank you, Dr. Jan.
Thank you.
Thank you.